Good afternoon, everyone. Thank you so much for this opportunity. I'll be talking about SBES, Simultaneous Bilateral Endoscopic Surgery. Traditionally, stones which when they were in two different locations in the same patient, they were dealt with in more than one session by the same surgeon, maybe 15-20 days later after one side had been taken care of. Gradually, we went from different sessions to the same session by the same surgeon consecutively, and finally to simultaneous surgeries being performed in the same patient. Why was this done traditionally? Primarily because of the prone position in which PCNL was performed. Also safety issues with the patients who were being operated on two different kidneys. What changed was the advent of supine PCNL, where we had continuous access to the lower tract in one particular position. Also, along with that, we had newer flexible ureteroscopes from which we could not only access the lower tract but almost the whole of the kidney. So, taking it further, that is how we reached ECIRS, where we could operate on one single renal system from above through a PCNL as well as below through a endoscope, through a flexible ureteroscope. Taking this idea even further, Gisti and colleagues joined two surgical teams and coined the term SBES, Simultaneous Bilateral Endoscopic Surgery, where two surgeons would be operating on the same patient at the same time, and usually it will be supine PCNL on one side and flexible ureteroscopy on the other side. We in our study have expanded this to include rigid ureteroscopy for lower ureteric calculi, also along with supine PCNL. And also, we have further expanded it to include stones which are in the kidney as well as large simultaneous bladder stones, and we have termed it simultaneous bladder and renal stone surgery. The key is the supine position, which offers us the opportunity to treat all this at the same time. So we had a prospective study of around 23 patients over 2 years, and all patients who were included were more than 18 years of age and less than 80, and multiple stones at different locations with surgical fitness and risk benefits explained. One side would be suitable for PCNL, the other side would be suitable either for flexible ureteroscopy or rigid ureteroscopy or a cystolithotrypsy. And we left out patients who had CKD, were pregnant women, or patients with active UTI. It required two teams of surgeons with a OR setup which could support two simultaneous surgeries going on. So coming to the results, we completed the procedures on both sides, and there were no intraoperative or perioperative events. Most importantly, there were no renal function derangement in any of the 23 patients. 13 of the patients had undergone SBES, where flexible ureteroscopy and supine PCNL was performed, and 6 patients had undergone PCNL with rigid ureteroscopy on the other side for lower ureteric stone, and PCNL with cystolithotrypsy for 4 patients. One of those patients was actually having thyrotoxicosis and was managed very well within the short period of time that we had. Our results, we were looking at efficacy, safety, and the outcomes of the procedure. So we had an operating time which was comparable to the published data, and it is actually lesser than that in a lot of cases. Most of our hospital stays were within 4 days. We had a stone-free rate of almost 91%, with only 2 patients having some 5 mm residual calculi seen in the later CTs. And 1 patient had fever, 2 patients had some hematuria, so that leaves us with a complication grade of Clavin-Lindo 0, that is no complications of more than 85% of the patients. So the definite pros are decreased anesthesia and operative times, surgical risk is reduced, the whole procedure is performed in one anesthesia, it's cost effective. The cons are that we need a special OT setup, and there will be 2 surgical teams which are needed. To conclude, it is safe, it is efficacious, and there is minimal morbidity. The ideal candidates are people with small burden stones with uncomplicated anatomy, and the impacts are quite obvious: short anesthesia, short surgery, and very short hospital stay, and a lesser chance for a second surgery with an early stent-free removal to normal activity. The challenges in front of us are we need more safety studies with larger cohorts, and we probably need a comparative data when a kind of a randomized study where simultaneous procedures can be compared to sequential procedures. Thank you.